afford to offer you this coverage anymore. And that is how this begins to spiral out of control. And so you see where the agenda is set. The agenda is set to get everybody on a trajectory towards the single-payer system. It becomes a self-fulfilling prophecy. And the political left, these people lay awake at night thinking about ways to collectivize, to socialize risk, and to collectivize things. And that is what they have accomplished. Now, if you look at the health care bill is one of these pieces of legislation that is unique. Most times, when a landmark piece of legislation is passed, it becomes more popular the more people find out about it. You just learn more stuff and you go, oh, I didn't realize that. Oh, that's better than I thought. This bill, Nancy Pelosi has no idea how ironic she was when she said, we've got to pass this bill in order for you to know what's in it. Well, she did, and we do. And people are not happy because what's happening? Costs are going up. So, now, during the debate, we were all told, we were basically chastised, if you really think about it. We were chastised, and we were told, essentially, the subtext was, you peasants, you don't understand the math. This is way beyond your depth. And you just need to pass this bill. Relax, pass this bill. You'll love it. It'll be good for you. Well, the bill passed, and we were admonished. We were told, remember, all these members of the administration, they're coming into these House hearings and all this, and they're saying, we're going to bend the cost curve. We're going to bend the cost curve. And they were practically walking around with their arms like this for about 3 or 4 weeks. Oh, what are you going to do on health care? Oh, we're going to bend the cost curve. All right. Well, the cost curve didn't bend, did it? It didn't bend down. It snapped up. Why? Because it didn't deal with the underlying problems of the cost drivers. So here's, I think, the remedy. The remedy is to focus in on a couple of things. Number one, health insurance carriers should not be insulated by state and federal law to allow them to dominate a marketplace, just sort of by fiat. There is absolutely no reason why the carriers shouldn't have to compete with somebody that's doing business in Iowa or Ohio or New York or California or Hawaii or whoever, wherever. Competition works, right? Competition brings costs down in nearly every other aspect of our lives. And yet, why is it that we determine that competition is not a good thing as it relates to health coverage? That's the first thing to focus in on, in my view. The second thing to focus in on in terms of restraining costs is you have to change the tort liability system. You have to make it so that doctors look at patients as patients primarily and not as plaintiffs. So that when somebody comes in and they're looking out over the landscape, and let's say you're an orthopedic surgeon, and you come in and you know exactly what's going on with somebody's knee, let's say. But there is just this little tiny sliver. It's like just such a remote possibility that it's something else. You know, it's not, but there's no, wow, if you're the doc, order the test. Play it safe. Order the test. Even President Obama, when he gave his speech before the American Medical Association in July during the healthcare debate, even Barack Obama acknowledged that defensive medicine drives up healthcare costs. And that is breaking the orthodoxy of his party, because for years it had been deny, deny, deny. There's, you know, just ignore the man behind the curtain. There's nothing to do that has to do with driving up costs as it relates to defensive medicine. Even President Obama acknowledged that there's a relationship. Now the problem is that his very signature healthcare law does essentially nothing. I mean, there's some lip service for some studies and some projects to look at this. But again, the irony is that the new Obama healthcare law actually penalizes the very states that have caps on non-economic damages. You got to fix that. And then the final thing is to have more consumer-oriented health costs, or health expenditures. What do I mean by that? Right now we have a system that, again, if I'm coming in and I'm to see you as my orthopedic surgeon, tell me your name. Gary. So I go to see Dr. Gary. Poor guy, I'll never sit in the front again. That's all you need, Gary. That's all I'm going to ask you to do for you. So I go to see Dr. Gary for, let's say, a bad knee. And I go in and I go, Doc, I got a bad knee. And he goes, okay, you need to go see, you got to go get an MRI. I say, okay, I'll go get an MRI. right now, the way the system currently works, I am not invested in figuring out what the cost is of the MRI, really. Right now, if I go and I don't even know how much an MRI costs, so is it $1,500? Is it $2,000? Is it $2,500? Is it $3,000 and they give you a car wash? I don't know. Right? Now, if I ask Gary, I say, doctor, how much is this procedure going to cost me? In our culture, the way this whole thing is set up, that's almost an offensive question, right? Now, you ask the plumber how much it's going to cost. You ask the electrician. You ask anybody else where you're transmitting money, you are asking about the cost. The two people that have the most to say about the cost of the relationship have nothing to say in our current system. He doesn't know, and I don't know. And yet this thing is happening and it's churning. That's irrational. So what do? You create programs. Some of them are things called health savings accounts, where people are spending their own money, or they control that money. It's put in by corporations and others and so forth, but they're using their own money that they have control over, and then what happens? All of a sudden, human nature is such that, hey, this is coming out of my pocket. I'm not just paying $200 in a deductible or something that I get some bill 6 months from now. But I am now inquiring about the procedure. Now, it's a little bit more complicated than I'm describing this cost piece. But what we need to be doing is moving in a trend line where consumers, users of healthcare, have an interest and have the ability to know what the pricing mechanism is. Because right now, if you call a health provider, if you call a hospital in the area, and you say, hey, how much is this going to cost me? They sort of look figuratively at the caller ID and they say, well, depends who's asking. Right? Are you Blue Cross? Are you Signal? Are you this? Are you that? Heaven help you if you're some chump off the street that's paying full retail. Right? And in some ways, you can't blame the healthcare providers in that fashion because they're negotiating based on volume, and I understand all that. But what it has done is it has created a distance of understanding pricing mechanisms as it relates to healthcare. And what I believe is that you don't throw away and go after the good things in a healthcare system that is high quality and an incredibly dynamic system, all for the sake of a social experiment. Let me tell you one quick story, and then let's open it up for questions. Okay. Medicare is obviously the public, it's the federal government program for health care for senior citizens. Medicare has a very old payment model, and it's called pay and chase. It's ridiculous. You would never design it this way. There's a series of reasons, sort of historically, as to why it's gotten built up this way, but it is this way. And essentially, Medicare pays money out, then chases it down later to determine whether the transaction was fraudulent or not. Pay and chase. So here's what happens. You're a Medicare hospital or doctor. They give you a provider number. And the provider number, you attach the provider number. You send in the bill that says, we did a tonsillectomy. No, you wouldn't do a tonsillectomy. We replaced a hip on Mavis, and they send it in, and it goes, well, it looks pretty good. Send it out. Great. Send it out. Pay it out. Now, here's the problem. Rings of organized criminals have figured this out. So what they've done is they have created systems, and I'm talking highly developed manipulative systems, that use this, and they steal numbers, and they set up false clinics. There is story after, if you go home and Google this stuff, it'll make you crazy. Actually, don't go home, please, because it'll make you crazy. But there is literally 10% of Medicare payments today are criminally fraudulent. And when I say criminally fraudulent, I'm not talking about some little old lady getting an extra back rub or something. I'm not talking about some doctor who's a hustler checking off an extra box or two. I'm talking about organized crime that is going after this. So much so that the Inspector General for Medicare, for CMS, said in Senate testimony about a year ago that it is more lucrative to be involved in Medicare fraud than to deal in crack cocaine